My name is Dr. John Best. I'm a sports and exercise physician with the Ortho Sports Group in Sydney. My practice is in Randwick, where I've been for 30 years. My body area interests in terms of musculoskeletal problems are disorders of the shoulder, the hip and the knee, and a lot of that has stemmed from my work with elite football codes. My involvement has been with the Australian Rugby Union, where I was the Wallabies doctor for a decade. I consult now to the National Rugby League and have had a short stint in elite football with the Premier League in London with the Fulham Football Club. As general practitioners, it can be very tricky looking at the management of osteoarthritis in the hip and knee, particularly patients in their 50s and 60s. And as an OA sufferer myself, who's had operative and operative treatment, I have very strong views on this. We're in a tsunami where in the West obesity has become common, and we now know that there are changes around metabolic health and arthritis that develops. And that helps me a lot in my management of patients who really aren't ready for surgery at this point in time. So with regard both OA of the knee and hip, what are some measures and approaches we can look at for non-operative treatment? Terrific studies from the Carolinas have indicated that weight reduction and exercise reduces pain by 25 to 50%. It's an enormous change in people's symptoms through lifestyle change. Quadricep strengthening, hip girdle strengthening, and low or non-impact exercise programs, so getting someone to move from walking to, say, a bicycle, is very effective. The second thing is inflammatory diets. There's more and more information on this. We're aware that people have very different metabolic health, but for those patients of yours who have insulin resistance, who are pre-diabetic or type 2 diabetic and are obese, the College and International Association of Rheumatologists in Europe push very hard weight reduction and the reduction of fat to reduce inflammation in the body. So the European League of Rheumatology have a beautiful paper looking at how adipose tissue produces high volume of cytokines which are pro-inflammatory. I didn't appreciate this. I didn't appreciate that fat not only causes increased mechanical load on joints, so for an extra kilo you're carrying through the hip and knee, you're putting in the order of 7 or 8 through when you're walking or going downstairs. But fat tissue acts as an organ. It releases inflammatory chemicals. So I do push quite hard, reduce processed foods and sugars for my patients, endeavouring to lose weight. Then we got issues of pain management and managing load. For pain management, analgesics and the judicious use of non-steroidals, when indicated, is useful. But corticosteroid injections still have a role when there is synovitis inflammation in the joint. Where else do we go from there? I'll leave out supplements because there is still a lack of clarity regarding certain supplements, such as fish oils or curcumin. But I want to just talk about 2 other injection options. The use of platelet-rich plasma and leading towards stem cells, and the use of hyaluronic acid. First of all, platelets, PRP. Research is coming through that in patients with generalised osteoarthritis, the use of PRP for the knee appears to be of value in about 70% of patients. I do tell my patients categorically, it's not about regrowing cartilage, but it's about controlling inflammation. The use of stem cells is still being researched. I believe it is the future, but we're not there yet. And finally, hyaluronic acid, HA. This has been available for 30 years in North America and Europe. There are different products in Australia. What is that? What is hyaluronic acid? Hyaluronic acid is a sticky gel that is a normal part of synovial fluid. So in a normal joint, the joint fluid is sticky. It acts as some sort of nutritional value or protection of the existing articular cartilage. People with osteoarthritis have very low concentrations of HA. So its use is of value for the knee. There is research on the hip as well. Colleagues of mine have kept working on. But the success rate is limited. You're looking at 70% of patients having an improvement in their ability to walk and load the knee, for in the order of 6 to 9 months. So, non-operative treatment of hip and knee arthritis, weight reduction, exercise, the use of non-steroidals and analgesics as needed, corticosteroids for inflammation, and the consideration of other injections such as platelet-rich plasma or hyaluronic acid. I hope you find that helpful.